Okay, well, I want to wrap up what we got started on last week, and I went through, since this was such a large lesson and had so much detail to it, I went through this afternoon and highlighted a bunch of stuff just so we would really hit the key information. And I also sent everybody a a handout with the bullet points on it or what have you. So hopefully that'll help make this a little more palatable. Because again, the psychology of the brain and the nervous system in general, or the physiology of the brain and the nervous system in general, is so vast, so extensive that it is tough to digest. So where we left off last time, where we talked about disorders of the meninges, and one of the first ones we talked about was a subdural hematoma. And we can if we think of the scalp, and then obviously we have the bony cranium itself, well, then we have three distinct layers of covering of the brain: the dura mater, the cobwebby like arachnoid mater, and then if this is our brain, we have the pia mater that follows along all of the gyri and sulci of the brain. And if we had a subdural hematoma, just like I have highlighted in our McGraw-Hill resources, is bleeding into the subdural space outside of the brain. So in this case, the bleeding would be in this region. And what ultimately would happen would be that the pressure from that blood accumulating would ultimately lead to damage to the brain. Pressure on the brain that, unless it was relieved, would cause potentially irreversible damage to the brain ultimately. Now, an epidural hematoma, okay, is a pooling of blood in the epidural space outside the brain. Okay, epidural, okay, epi means above. So if this is the skull, this would be the pooling of the blood above the dura layers. Okay, so an epidural hematoma, blood accumulating just above the dura layers. Meningitis, okay, again, inflammation of the meninges, bacterial meningitis, very common. There's viral meningitis, but again, inflammation of the meninges. Oftentimes, meningitis is going to be people who are living in confined spaces. College dormitories, UVA or Virginia Tech a few years ago had an outbreak of meningitis. Barracks where soldiers might be staying, prisons, things such as that, might be common to see an outbreak of viral meningitis. Okay, and then meningioma, tumor originating in the arachnoid mater. So in this layer beneath the dura mater, the tough leathery dura mater, okay, in the arachnoid mater is where we'd have the meningioma. Okay. Bell's palsy. Okay. This is a disorder of the cranial nerves. And just like our picture shows, in Bell's palsy, you have drooping of the facial muscles, usually just on one side. And so, as I highlighted, a disorder of the seventh cranial nerve, the facial nerve, okay, causing a sudden onset of weakness or paralysis of facial muscles. Okay, so again, sudden onset and it leads to paralysis, hemifacial, which means just half of the face. Trigeminal neuralgia, okay, or tic douloureux, is intermittent shooting pain in the area of the face and head, innervated by the fifth cranial nerve. One of the, with my background in cardiac rehab, a lot of females will have jaw pain as their sign of angina. And I remember years ago, one of our patients actually had trigeminal neuralgia, and every cardiologist she went to would always say, well, you know, you're having angina, and they would keep doing cardiac catheterizations on her. But it finally took a neurologist to realize that it wasn't angina and jaw pain, that in fact it was trigeminal neuralgia. So again, that's going to be the fifth cranial nerve. Horner syndrome, okay. Unilateral droopy eyelid, okay. Small pupil and a decrease in perspiration on the face. And just as it says in the text, it can occur in lung cancer patients and injuries to the head, neck, and cervical spinal cord. So our next focus point, learning objective, is disorders of the myelin sheath. And we talked about before that if this is our neuron, and these are the dendrites, these are receptors, this is the cell body, this is the axon, and then at the very end we have the synaptic terminals. But along the length of this axon, we have a coating of myelin. And they always kind of describe it as a jelly roll appearance. But between the myelin, we have little areas where the nerve is not myelinated, and we call those the nodes of Ranvier. And that allows the electrical impulse to skip along the length of the axon and get to the synaptic terminals much quicker. Well, if we have a disease in which we lose myelin, that dramatically decreases the speed of the impulse moving along the length of the axon. So again, demyelination of the neuron is going to be a destruction of that fatty tissue, the myelin, that surrounds the axon. Guillain-Barré syndrome, okay, disorder of the peripheral nervous system, where the body makes antibodies against the myelin. Okay, that's going to slow nerve conduction, leading to muscle weakness and paresthesias, a loss of sensation. Okay, Guillain-Barré syndrome can be treated, and the recovery can be 100%, but it's a very slow process to recover from Guillain-Barré syndrome. Demyelination of the nerve fibers in the central nervous system, the brain, spinal cord, and the optic nerves. Multiple sclerosis is an example of that. Okay, and it too is going to lead to a slow down of the nerve impulses, and ultimately that can lead to a lack of muscle strength, muscle output, power output, and gradual weakness associated with disease as the disease progresses. Okay, there will be periods of exacerbation and remission, and again, during periods of exacerbation, weakness is going to be more pronounced. During periods of remission, the patient will feel more like their old self. But the periods of remission and exacerbation can become more pronounced as the patient gets older and the disease progresses. There's no known cure for MS, but there are disease modifying drugs which slow down its progression. Other diseases of demyelination, or excuse me, other causes of demyelination include injury, ischemia, toxic agents such as chemotherapy or radiation, cognitive disorders such as Tay-Sachs disease, after viral infections or vaccinations, post-infectious encephalomyelitis is a concern as it could lead to demyelination as well. Okay. Our disorders of the spinal cord injury can basically be broken down into a severed spinal cord, and just as the name implies, that's where the cord is actually cut. A contused spinal cord where it's bruised due to impact, due to force, and then a compressed spinal cord. For example, herniated discs, intervertebral discs putting pressure on the spinal cord could lead to debilitating lack of spinal innervation depending on what level it is. Anything below the level where the herniation is occurring and putting pressure on the spine would be affected. And just as that next highlighted area says, loss of function occurs below the area that is contused or severed or where there's compression. So if somebody has a problem in their thoracic region, then they still may have use of their arms, but anything below the thoracic region, they would have no control over. Now, somebody like Christopher Reeve, who had a fracture at C1, C2, well, of course, he had no control over anything at that point. Even breathing for him had to be accomplished by a respirator. Other disorders include acute transverse myelitis, localized disorder of the spine that blocks transmission of impulses up and down the spinal cord. People with Lyme disease, syphilis, or tuberculosis, or inject heroin or amphetamines intravenously are at risk for developing this disorder. And again, nerve impulses have to travel from sensory nerves in our periphery up the spinal cord to the brain, and then efferent impulses are going to be the response by the brain and spinal cord to ultimately cause some sort of an effect to occur. A muscle will contract, a gland will secrete. So if there's a blockage in the impulse moving up to the spinal cord and brain, or from the brain and spinal cord down to the periphery, then there's going to be a loss of function, a loss of input, or a loss of the ability to react to the input. Subacute combined degeneration of the spinal cord due to a lack of vitamin B12, poliomyelitis due to the poliovirus. For the most part, it is eradicated, but there are still some cases and people still who may have had polio through one of the major epidemics in our history. There could still be effects, those people showing the effects of the disease. It leads to paralysis, especially muscles of the respiratory system. That's what leads to patients back in the day needing to be in an iron lung. Motor neuron disorders occur when motor nerves in the spinal cord and brain progressively deteriorate. This leads to muscle weakness that can progress to paralysis. ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease, is one of the most common of those motor neuron disorders. And again, it's going to lead to paralysis of the diaphragm, which ultimately leads to respiratory arrest. Disorders of our peripheral nerves. Oops. Mononeuropathy is damage to a single peripheral nerve, prolonged pressure on a nerve that runs close to the surface over bony prominence, such as carpal tunnel syndrome. Okay, the median nerve at the wrist is compressed between the wrist bones and underlying ligament. Ulnar nerve palsy, nerve damage occurs at the ulnar nerve that crosses too close to the surface over the humerus at the back of the elbow. So that may be a case where the ulnar nerve gets damaged and ultimately leads to a sensation of pins and needles all the time. Peroneal nerve palsy. Okay. Nerve damage that occurs at the peroneal nerve that passes too close to the surface near the back of the knee. The next thing I highlighted was herpes, the herpes zoster virus, and people will typically get chickenpox relatively early in their life, but that herpes varicella zoster virus can lie dormant in the nerves for decades and manifest itself again when the immune system is debilitated and ultimately creating a pattern of rash like we see in that picture. The rash follows the dermatome that is innervated by that particular nerve. So the herpes varicella zoster virus, okay, infects the peripheral nerves, okay, and then ultimately, just as it shows here, follows along the peripheral nerve that innervates this region of the body. Okay, and we call that a dermatome. For example, my mother had cardiac bypass surgery, and after her CABG, she, because of her immune system being down, because of all of the needs of her body to heal from the surgery, ended up getting shingles. And so again, in a situation where your immune system gets down, it makes it possible for that virus that was dormant for so many years to manifest as shingles. Okay, that's why older adults, of course, are urged to get the shingles vaccination. Neuromuscular junction disorders occur where the nerves come into contact with the muscle fibers and interfere with the neurotransmitter acetylcholine. We talked about neurotransmitters a little bit. They bridge the gap, that synapse between a nerve and another nerve, a nerve and a muscle, or a nerve and a gland. In this case, the neuromuscular junction is going to be when we have a neuron coming into contact with a muscle, and this is the synapse that must be bridged. And in this case, acetylcholine is going to be the neurotransmitter that is secreted by the presynaptic nerve, and it is going to ultimately bridge the gap at the synapse and innervate this muscle fiber and cause contraction. Now, in a case of a disease like myasthenia gravis, then the acetylcholine is going to be attacked by antibodies produced by our own body. And as it states there, the manifestations that are common are drooping eyelids, weak eye muscles, difficulty swallowing, and then muscle weakness in the arms, okay, or excuse me, in the limbs in general, arms and legs, okay. Botulism is a form of food poisoning caused by Clostridium botulinum toxin, and it too can lead to um, deficits of acetylcholine at the neuromuscular junction. Insecticides, organophosphates, can do the same thing, lead to a lack of acetylcholine at the synapse. Congenital anomalies of the nervous system. Congenital, of course, means something that is going to be acquired during fetal development. And in this case, the first disease is a teratogen. It's an agent that can cause malformations of an embryo or fetus, and it can lead to conditions such as anencephaly, okay, absence of the cerebral hemispheres. Okay, and so here's a newborn with anencephaly, and we can see that there is no cranial vault. And so that means that without the cranial vault, the more advanced portions of the brain never develop. And of course, not only is the skull malformed, but overall development of the brain is going to be dramatically limited. And of course, it's going to ultimately be fatal for the newborn. Microcephaly, decreased head size and associated with small cerebral hemispheres, moderate to severe motor and mental retardation. Hydrocephalus, in this case, the fluid actually, cerebrospinal fluid, actually, because the bones of the skull are not fused together, their fontanelles are pushed apart by extra cerebrospinal fluid. And so that ultimately leads to malformation of the head like we see in this particular newborn. Okay. Fetal alcohol syndrome, again, a congenital disease, can occur when a pregnant woman drinks alcohol. The child with fetal alcohol syndrome may have a small head, narrow eyes, a flat face and nose. Intellect and growth are impaired. Spina bifida occulta, or excuse me, spina bifida. And basically, spina bifida is going to be where we actually see a meningocoeli, where we see perforation of the tissue and the spinal cord bulges out. So here we see an infant with the meningocoeli, and that leads to the spinal cord basically being outside of the vertebral column. And they said oftentimes you will see a little tuft of hair over the meningomyelocele. So that's kind of a dead giveaway that that newborn is born with spina bifida. Okay. Now, some of our diagnostic procedures for neurology. Lumbar puncture, that was a spinal tap where we actually took a needle and went through the vertebrae, and we pierced through the dura mater, the arachnoid mater, the pia mater, and got into the cerebrospinal fluid that bathes the central nervous system. And this can be handy to find out if some sort of a pathogen has infected the central nervous system. Electroencephalography, these are going to be electrical output of the brain. Just like in cardiac rehabilitation or on a telemetry floor, you put electrodes on someone's chest to monitor the electrical output of the heart. In this case, we're going to be monitoring the electrical output of neurons in the brain. CT, or computed tomography, a computer-enhanced X-ray technique that generates slices of the brain. CTs can literally create slices of tissue so thin, eighth inch, quarter inch, whatever the case may be, and take section after section after section and look at all of the structures of the body. The Atom Project, for anybody that's familiar with that, in terms of study for anatomy and physiology. That's a CT generated scan and dissection. MRI uses strong magnets to create a magnetic field, and with the use of computer also create images. Magnetic resonance angiography. Angio of course means vessels, and that's going to be a device used to look at the flow of blood through the vessels. A radio opaque dye is going to be injected into the blood vessels, and then it can be seen how it's picked up under the MRI and give you visual images. Cerebral angiography, it's going to be just a radio opaque dye injected into the vessels, which nourish the brain. Go ahead. Oh, I'm sorry. I thought somebody had a question. Oh. How about now? Does it seem like it's a little better? Okay. Well, let's try it out a little bit and see if it's a little better. Um, let's see. Color Doppler ultrasonography uses high frequency sound waves to show the different rates of blood flow through the arteries in the neck and the base of the brain. It can be used to evaluate TIAs and strokes. And again, a TIA was a transient ischemic attack. That's where the brain has had a microembolus, and what ultimately happens is enough pressure pushes that microembolus through the vasculature, and the deficits resolve themselves. But in a full stroke, of course, the deficits don't resolve themselves. Echoencephalography uses ultrasound to produce an image of the brain in children under 2 because their skulls are thin enough to have waves pass through them. Still getting feedback? Oh, okay, go ahead. Uh-huh. Mm-hmm. Mm-hmm. Well, if it was something, yeah, if it was something neurological, then I would have to think because ultimately that is a neurological deficit that was congenital, that anything that was neurological from that point forward in their life would all be attributed to the spina bifida, and so therefore that would end up being primary diagnosis. Um, Spina bifida, and then secondary, I guess in the example you gave, as a headache or something, that would just simply be a side effect or a symptom related to the spina bifida. That wouldn't be neurological, so like a cough wouldn't necessarily be attributed to that. But if it was something that would have a neurological origin, then more than likely it's always going to be the spina bifida would be the primary diagnosis. Mhm. What now? Well, if they had a cough that was attributed to, say, a pathogen, then that wouldn't be attributed to the spina bifida because it would be a neurological issue. It could only be a neurological issue, so to say, that would be attributed to the spina bifida. If it was a viral infection, a bacterial infection or something like that, that wouldn't necessarily, if that was the source of the cough, then you wouldn't be able to attribute that to the spina bifida. Yeah, because I think it would have to be something that was neurological. Now, I guess if they said that the patient had a cough and the uh, it was idiopathic, they couldn't find any underlying cause, no viral pathogen, no bacterial pathogen, then maybe in that particular example, they could potentially attribute it to the spina bifida. But to me, they would hunt for primary cause of the cough, and if they found, infection of any type, then I don't think there'd be any way that you could link that, since spina bifida is a neurological condition. No, no problem. Ha 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 ha, right. Let's see. Ha ha ha. Uh, myelography. Okay, so we were working through the different ways to diagnose various nervous disorders. Uh, Positron emission tomography involves attaching radioactive molecules onto a substance necessary for brain function, and they mentioned glucose. So that radioactive molecule can then be traced throughout the vasculature of the nervous system, and then as the blood flows and such, then they can make determinations about where there may be pressure on the brain due to a intracranial bleed, where there may be blood accumulating below the dura, and whatever the case may be. Myelography, use of x-rays in the spinal cord after, again, a radio-opaque dye has been used. Um, Electromyography, placing small needles into the muscle to record its electrical activity at rest and during contraction. Somebody had paralysis, for example. That would be a way to determine the extent of the paralysis, where their muscle impulses, or electrical impulses, I should say, conducted that were trying to stimulate the muscles, and were those impulses successful? Nerve conduction studies measure the speed at which motor or sensory nerves conduct impulses. Then pharmacology of the nervous system. Okay, so psychoactive drugs, as it says, are able to change mood, behavior, cognition, and anxiety. They are classified into several families: stimulants, sedatives, inhaled anesthetics, opiates, opiate antagonists, tranquilizers, antidepressants, anti-analeptics, psychedelics, and marijuana. And starting at the top, the stimulants include caffeine, nicotine, amphetamines, cocaine. They enhance the stimulation provided by the sympathetic nervous system. Remember, the sympathetic nervous system is the fight or flight method. If we are getting into our car late at night after I teach night class, for example, and somebody jumps out of the shadows and says, "Give me your keys, give me your wallet," and I only have a split second to determine if I'm going to stand there and fight or if I'm going to turn and run. So very quickly, adrenaline, epinephrine, gets released from my adrenal glands, and so that stimulates my muscles to contract with more force, to punch harder or run harder. My heart can contract with more force. It contracts more times per minute. I can take in more oxygen because I can inhale more atmospheric air. The smooth muscle around my airways opens up, and that allows more air into my respiratory passageways. All of that occurs as a response to the fight or flight mechanism. Well, caffeine, nicotine, amphetamines, cocaine, they all are enhancing the body's sympathetic nervous system response. Not necessarily in a good way. Too much of any of those obviously can lead to adrenal gland burnout and a whole host of other um, deficits. Heart problems, for example, heart palpitations initially, and then even potentially cardiac arrest. Sedatives do just the opposite. Uh, Alcoholic beverages have ethanol in them. Barbiturates, uh, meprobamate, uh, decrease sensitivity to the postsynaptic neurons to quiet the nervous system. It acts on the sleep centers of the brain to induce sleep. Inhaled anesthetics such as isoflurane act similarly to but are more powerful than sedatives. Opiates, morphine, codeine, heroin, methadone, oxycodone depress nerve transmission in the synapse of sensory pathways of the brain and spinal cord. They inhibit centers of the brain controlling coughing, breathing, and intestinal motility. Okay, of course, they do have highly addictive properties. Opiate antagonists against opiates, such as naloxone and naltrexone. Um, Narcan is something that now, with the opioid uh, disaster that is going on in this country, being from West Virginia, opium uh, use, those types of products, those types of medications, is just rampant uh, in areas of West Virginia. And so that's actually been included in basic life support by the American Heart Association, training on how to quickly assess somebody who may have overdosed on opioids and needs Narcan to basically save their life. They aren't cardiac arresting, they are having an overdose of an opioid. Tranquilizers, chloromazepine, haloperidol, benzodiazepines, Librium, Valium, Xanax act like sedatives but without their sleep-inducing effect. Antidepressants all increase the amount of serotonin. That's why medications like Zoloft and Prozac are called selective serotonin reuptake inhibitors. They act to keep serotonin in the synapse longer. And with serotonin in the synapse for a longer period of time, that allows that part of the brain to be stimulated and ultimately elevate the mood. Okay, so selective serotonin reuptake inhibitors like Prozac and Zoloft, they do elevate the mood because, again, serotonin isn't broken down as quickly, and ultimately that leads to the enhanced effects in lessened anxiety, lessening of depression. Anti-epileptics. Phenytoin and carbamazepine are anti-epileptics. And they keep stimuli from passing across the synapse. In other words, in this case, they block. Okay. They block the neurotransmitter. Thus, the information doesn't get from the neuron to the next neuron or to the muscle fiber or whatever the case may be. In this case, we're talking about a neuron in the brain, and so it stops the seizure by keeping that impulse from crossing over the synapse. Psychedelics distort sensory perception. Plant products such as mescaline, psilocybin, dimethyltryptamine. Okay, they can also be synthetic ones like LSD, lysergic acid diethylamide, methyl dioxymethamphetamine, MDMA, and that's ecstasy, phenylcyclidine, angel dust, or PCP. They increase the amount of serotonin in the synaptic junctions, and some of them also have amphetamine-like stimulation. And then marijuana has the active ingredient THC, tetrahydrocannabinol, and it produces drowsiness. It produces the drowsiness of sedatives like alcohol, the dulling of pain like opiates, and in high doses the perception of distortions like psychedelics. Okay, and tolerance does not occur with marijuana. Okay, that was it for the nervous system. That was quite a chapter. Do you get? Sure. Well, in the case of a drug like um, ecstasy, it does have effects that are very similar to allowing a neurotransmitter like serotonin linger longer in the synapse, thus producing that extended high feeling. And for lack of a better way to put it, it does distort perception just because of the fact that it does make the serotonin available for longer periods of time. And that leads to, you know, for at least as long as the drug is continued to be taken, those uplifted feelings. But again, just like most other drugs and medications, recreational drugs or prescribed medications, it does in fact have um, a tendency for the person using it to develop tolerance. Now, marijuana, as they said, is a drug which patients don't develop tolerance to, and has many of the same benefit. Well, it produces the same effects, so to say, as some of those other drugs, all in one potential drug, or in some uses in some areas now it is a medication. But again, most of those medications, they do have to be cycled because the risk for developing tolerance is so high. But again, it works in the same way that our body works naturally, and that's kind of what makes them so psychologically as well as physiologically, you know, addictive, is because of the fact that it works with our own body's chemistry, and in this case, the chemistry of the neurotransmitter to stimulate neurons in the brain of those areas that lift up our spirits, the limbic system. So hopefully that helped. That's part of it, definitely. and there, right. There will be people that have idiosyncratic responses to practically any medication. I've got a really good friend of mine that got me into powerlifting. If he takes Ambien, he's awake for 3 days. Most people would have just the opposite effect from it. They'd be down for the next 3 days. But some people do have idiosyncratic reactions to many different medications. And so recreational drugs would, of course, be, similar in that regard. Now, the other thing, too, is that um, in many cases, you are right. If they have something in there which is an impurity, then that very well could be what causes um, some sort of mishap with the body's chemistry. Now I can't remember who the athlete was, but they use synthetic marijuana, and I guess that stuff has some just horrible side effects in terms of hallucinations and things that it makes people do. So, again, I think if it's taken in its natural state, in its most pure form, but you probably have a very tough time getting that in this day and age because of how much of a big business drugs are. So they probably stretch it out as much as they can by adding other things in with it. I guess if you could get marijuana from a reputable medical marijuana farm that met specific criteria and everything, then you might get something which would have the medicinal effects and what have you. But I guess in any other form, it's probably risky just because of the fact of what they might actually add to the marijuana, more so than the actual drug. And I think even with smoking, nicotine, um, has its own effects, but there's so many different things in cigarette smoke that have just powerful effects on the body. Um, gosh, hydrogen cyanide, for example, that paralyzes the cilia in your respiratory tract. Again, so it's not the nicotine that is the issue. It's some of the other chemicals involved with the nicotine that have so many detrimental health effects. Sure.